Trigger warning. This content includes sensitive material related to suicide, trauma, and/or severe mental health concerns.
I want to thank ARPA for the opportunity to present to you all this morning. Thank you so much, Dr. Griffin, for the invitation. Dr. Rutherford, I really appreciate this. So this morning I'm going to be talking about mental health in the state of Arkansas, and specifically with the focus on suicide. I became interested in the topic probably about 5, 6 years ago. This was, right before the pandemic and during the pandemic, where I noticed some pretty interesting trends in the state related to suicide. And, I was looking at the data, I noticed that, we lose about 500 to 600 people a year due to suicide here in Arkansas. And my question is like, why aren't we sounding the alarm? Why aren't people doing anything? Like, we should really be drawing more attention to this. And so the information that you'll see today is just really kind of a culmination of a lot of work that my colleagues and I, we put in to help raise awareness and provide some information regarding suicide here in the state. Okay, there we go. So again, this is just some of the objectives, or I'm sorry, disclosures. No financial disclosures, and these opinions are those of myself and not necessarily those of my employer, the Department of Health, or UAMS. So this is just kind of an overview of what we're going to be talking about. Again, just describing the burden of suicide here in the state of Arkansas with the focus on youth. And then we'll be looking at the youth population stratified by race and ethnicity as well. And then we're going to look at some of the trends in suicide data, specifically hospital admissions, emergency department visits, and of course, deaths. And then I'm going to pivot towards the end of the presentation to talk about a project that we recently had published in a journal where we looked at, excuse me, the association of people running out of their psychotherapeutic or their mental health medications and as a potential trigger for suicide. So these are a couple of the data sources that we're going to be exploring, specifically the Youth Risk Behavioral Survey and data from the Arkansas Department of Health, specifically looking at vital records, death certificates, and our hospital discharge data set. And just a little bit about the hospital discharge data set, well, data in general and specifically at the Arkansas Department of Health. If you have not had the opportunity to explore some of the data that are collected at the Department of Health, I would strongly encourage you to do so. I know many of you all are involved in research. I can see from the poster presentations that are here, but I tell people that we collect data on people from the time they are born to the time that they die and everything in between. So hospital admissions, if they're, people diagnosed with cancer, there's a cancer registry. We have a trauma registry. We have a traumatic brain injury registry. We have a ton of data, and it's available to researchers should they want to use those for various projects. So I want to point out that last month was National Suicide Prevention Month, where mental health advocates such as yourself used this as an opportunity to talk about resources, prevention efforts. People share stories to promote suicide prevention awareness. It's also during this time that we would like to share resources such as the 988 operating Suicide Crisis Line that is actually housed and managed at the Department of Health, where we have people who will link individuals who are in crisis to local resources. And I think that's extremely important to highlight that we are connecting people with resources here in state. And so, certainly want to shout out the Department of Health for their endeavor to address suicide. All right, so I'm going to apologize in advance. As Dr. Griffin stated earlier, I'm an epidemiologist, and so I rely heavily on data. So my slides are going to be pretty data heavy. We're going to walk through the data, though. I'm trying not to overwhelm you with a lot of data. I know people eyes glaze over when they hear about statistics and all of those things, but those things excite me. So just please accept my apologies in advance. All right, so since 2013, more than 500 Arkansans died by suicide each year. And when you put that in perspective, that's enough people to fill a Boeing 747 jet and crash it every year. So imagine the uproar that would take place if every year a jumbo jet crashed and there were no survivors. And so we are filling this jet every year with men, women, children, minority population, white individuals, Hispanics, and we are sending that plane to crash every year. And that is a tragedy, in my opinion. When we look at just the overall trends, 2017 was probably one of the worst years that we had in suicide. And I want you to keep that in the back of your mind, 2017, because we're going to talk about this later on in the presentation in terms of what happened in 2017 that may have been associated with this big spike that we saw in suicide. In 2023, which is the latest year of data that we have publicly available, we saw that there were 626 deaths. And in 2021, well, I'm sorry. So this represents a 31% increase in suicide rate since 2013. And I'm not sure if you all know this, but the state of Arkansas have the 11th highest rate of suicide in the nation. And again, to put things in perspective, the state with the highest suicide rate is Alaska at 28.2, and New Jersey has the lowest suicide rate at 7.2 per 100,000 individuals. And so another thing to point out is that each year more than 4,000 Arkansans are admitted into the hospital or seen in the emergency department due to self-harm. So again, here's data. I have here the age-adjusted suicide rate where we compare our state to the national average. And there was a point in time where we saw in 2018, 2019, where the rates were starting to come a little closer to the national rate. But then in 2020, we started to see the rates increase. And as you all know, there was something that took place in 2020 that kept a lot of us busy, I'm sure. And then we saw a big peak in 2021 where the suicide rate in Arkansas was about 55% higher than the national average. And you can see again in 2023, those numbers are going in the wrong direction in relation to the national average. So I want to take a moment here to talk about data that was obtained from the Youth Risk Behavioral Survey. So this survey is administered every couple of years, and we've established that our young people are dealing with depression. I'm sure you all see a lot of this in your practice or know people, friends, family members who have teenagers, young individuals who are suffering from depression, hopelessness, and just a poor sense of self-worth. And I want to show you how these data translate into this survey, especially. So over the years, the rate of high school students who have considered suicide has been higher than the national average, but not really by much if you look at it, especially in 2021 where the national rate was a lot higher than, or a little bit higher than the state rate. But in 2023, we saw the national rate go down and the Arkansas rate continue to increase. And so, again, putting this in perspective, about 25% of respondents have indicated that they have considered suicide within the past 12 months. That's 1 in 4 high school students. That's a lot of individuals when you think about it. So here are those data when we stratify by race, and I thought it's really important to look at data stratified by different populations, looking at the racial breakdowns, because, you know, growing up as a black male, I was always told that black people don't die by suicide. And that's a myth, a big myth, especially now. And so when we look at individuals, young high school students who are considering suicide, you know, we see that the rates, especially in 2023, are not that much different from their white counterparts or Hispanic counterparts. And you'll see later on in the presentation, oh, lost our, okay, getting our slides back up. All right, thank you so much. All right, so again, I want you to look at 2017, and you can see that the rate among white high school students increased, black high school students increased, and there was a small increase among Hispanic youths. And again, just kind of start thinking about what happened in 2017, okay? So now the next survey question that was administered was looking at students who actually made a suicide plan. And so now we've shifted from thinking about suicide, considering suicide, to now we're coming up with a plan. And so one thing that really that you'll see that stick out is in 2017, we see another big jump. You know, in Arkansas, 26.1% of the respondents have considered or made a suicide plan, okay? And then we saw the effect of the pandemic, where we've seen rates increase in 2020 and 2023. So now we are, again, looking at these data stratified by race. And again, I think it's important to look that, you know, in 2017, all races and ethnicities saw an increase. We saw the greatest increase among Hispanic high school respondents, you know, with more than a third who have made a suicide plan within the past year of this survey being administered. And then if we look further in the data, further years in 2023, we see that, you know, there's a convergence of our statistics. But again, they are very, very high. I mean, you know, again, we're talking about 1 in 4, 1 in 5 high school students who have made a suicide plan. All right, so now we've gone from considering suicide to making a plan to now we're asking the question of how many students have attempted suicide. And again, you can see that in Arkansas in 2017, there's that spike that we see that took place, and the numbers started to go down, and then we see another increase in 2023 of respondents. About 15% of Arkansas respondents have indicated that they have attempted suicide in the past 12 months. And seeing those numbers stratified by race, I don't know if you guys have been tracking this, but in the past slides, African American black respondents have had probably one of the lowest lowest response rates of those who have considered suicide and made a suicide plan. But now when you look at those who actually attempted suicide, when you stratify by race, you can see that black respondents, 17%, have actually or indicated that they have attempted suicide within the past 12 months, and which is much higher than the other respondents' race and ethnicities. And so to me, this speaks to this may be more of an impulsive action than anything else, where they may not necessarily be considering it or making a plan for it, but in terms of actually attempting suicide, African American respondents are among the highest. All right, so let's go to 2017. What happened? I don't know if you guys remember the documentary or a drama that came out, 13 Reasons Why, in 2017. And, you know, for those who are not very familiar with it, I didn't watch it or anything like that, but apparently the series will, it focused on a series or a group of high school students and the aftermath of suicide of a fellow student. Before her death, she left behind a box of cassette tapes in which she details the reasons why she chose to end her life. as well as the people who she believed were responsible for her death. And I wanted to highlight this because there were quite a few studies published where they were able to associate the increase in suicide and suicide ideation, suicide attempts to this drama. And so, I think it's really important to acknowledge the impact of media and movies and how it could really impress, especially our younger population. So I want to shift gears a little bit and talk about just kind of self-inflicted injuries and deaths to give a general picture in terms of what's going on here in the state of Arkansas. At the Department of Health, we have our state divided into 5 public health regions. And so I'm going to be presenting these data according to these regions, and so that you all can see where we are having some hot spots in terms of suicide attempts, hospitalizations, and deaths associated with suicide. So this first slide is looking at those individuals who were seen in the emergency department due to self-inflicted injuries. And so you can see that in the northwestern part of the state, among the younger population, we see the highest rate of suicide, and these data are from 2023, excuse me for not saying that. And then we have the age specific rates so that we can compare across various populations in the state of Arkansas. But you could see that in 2023, we had a rate of 178 per 100,000 young people, 19 years and younger, who were seen in the emergency department due to self-inflicted injuries. And we look at that in relation to the state average, where at the very far end of the screen, again, I'm looking at the younger population, we have a state average of about 143 per 100,000 individuals seen in the emergency department due to self-inflicted injuries. So now I want to shift and talk about those people who actually admitted into the hospital due to self-inflicted injuries. And we see a little bit different picture here, right? So the first slide was looking at people who were seen in the emergency department. So they were seen in the emergency department and discharged home or to another facility. These are people who are actually injured, they hurt themselves enough so that they needed to be admitted for medical care. And if you look, you can see that the highest bar, Northeast Arkansas, where we look at individuals 20 through 44 years old, are more likely or have the higher rate of being admitted into the hospital. And so when we see this type of injuries, think of your poisonings, taking a lot of pills where they have to be, monitored for an extensive period of time, or they've suffered enough internal damage to where they need additional medical care. And so these are going to be the majority of type of injuries that you will see in these hospitalization rates. And then the last slide that I want to show here, where we look at the rates, is just looking at suicide in Arkansas in 2023, again stratified by age group and presented according to the public health regions. And so you can look at this and see in the southwestern part of the state, we have among the highest rates of individuals who die by suicide at about 52 per 100,000, followed by the northeastern part of the state. And so, and I bring this up because I think there's an opportunity to intervene, right? If you're wanting to address, where we have mental health deserts, where people cannot or do not have access to mental health providers, there's an opportunity to look at where we have some of the higher rates of hospital admissions, emergency department visits, and deaths in the state. I just doing something. All right, so allow me to shift now to talk about a study that I mentioned earlier at the presentation that was recently published, where we look at the risk of suicide and medication depletion. So I'm going to start off by just talking about some national statistics. After I take a sip of water. So each year about 50,000 Americans die by suicide. Again, here in Arkansas, about 500 to 600 people, most recently more than 600 people per year. But it's estimated that about half of those individuals receive treatment for their mental health disorders. And so it's been widely reported that mental health conditions such as substance use disorders, chronic pain, you know, are among some of the risk factors for suicide. When people have been diagnosed with a mental health condition, they typically go under the care of a clinician or practitioner for medication management, because it's important that the practitioners follow these individuals closely, because it's very common for there to be a need to adjust their medications as needed, based on whether it's side effects or the medications are not working as intended. So it's estimated that about 16.5% of adults, which is about 42 million individuals, take some type of psychotherapeutic medication. And so when I mention psychotherapeutics, I'm talking about your SSRIs, your antidepressants, anti-anxiety medications, lithium, antipsychotics, and others. Estimates show that when most people have, most people have their medications managed by a primary care physician, not necessarily a person who has been specifically trained in the area of mental health. And I thought that that's important to note, because especially here in Arkansas, and when you go to the rural parts of the state, there is a big shortage of mental health providers who can address mental health conditions directly. As a result, a lot of people go to their primary care physicians for their medication management. And, primary care providers, God bless them, God love them, they see a whole gamut of different conditions. They have to manage blood pressure. They have to manage cholesterol, chronic conditions. And so now they are being, I'm not going to say bombarded, but for lack of a better word, they are being inundated with, people who are suffering from mental health conditions, and now they're having to manage their medications as well. So I took this figure from a study that was published a few years back, where we are looking at the type of providers who are prescribing or managing medications for individuals who are suffering from severe mental health disorders. And what I want to point out is that, I'm sorry that the words are a little small, but you have anti-anxiety drugs, antidepressants, antipsychotics, hypnotics, and anticonvulsants. But, especially in the rural parts of the country, and I would imagine that the same would be true here in Arkansas, about 75% of those patients are managed by primary care providers. And so again, you're talking about providers who are looking at a wide range of conditions, chronic conditions, acute conditions, and now they're 75% of population, where we know there's a lot of individuals who are dealing with mental health conditions, are being seen by their primary care providers. Now, I want to be very clear that the literature is, extremely clear in terms of psychotherapeutics reducing the risk of suicide. And this project here is not necessarily to combat that at all, or to contradict that. In fact, probably quite the contrary. When we know that people take their mental health medications as prescribed, there is a decreased risk for suicide. But this project, what I wanted to look at specifically is when an individual stops taking their medications. Is that a trigger or an acute event that would precipitate suicide? And the science behind this is very clear as well. We know that whenever people stop taking their medications, there is an increased risk for other symptoms such as insomnia, GI issues, anxiety, depression, hallucinations, and more frequent episodes of depression and despair. And the last three that I like to point out is that we know that these are increased risks for suicide. And the National Institute for Mental Health is very clear in stating that patients should consult with their providers if they are wanting to discontinue or taper their medications, so that that provider can work with them and create a plan that would allow for the safe taper or discontinuation of these medications. It's also very important to note that these symptoms of withdrawal syndrome can appear within days of a person stop taking their medication, which was really the impetus behind our project, because we wanted to see if that was a trigger for suicide in the state of Arkansas. So after being out of school for nearly 7 years, I had a great idea that I would take a course. That I would take a course that would teach me how to work with claims data. Claims data is a very rich source of data for research. And for those of you all who don't know, we have a tremendous resource here in the state of Arkansas called the All Payers Claims Database. And I'll talk about that here in just a second. But it is a wonderful, wonderful resource. So again, going back to the research question, we wanted to know if there's a temporal association with running out of psychotherapeutics and the risk for suicide. So I'm going to get very technical here, but I'm going to try to walk through it. We conducted what's called a case crossover study design to determine if there's an increased risk for running out of psychotherapeutics in the week before that person died by suicide. So what we do, we compare the exposure, which is running out of suicide during, what we have 12 one-week windows of time. So I'm going to just point to this here. So each one of these boxes represent 1 week, right? And so here at the very end, we have the event, which is the suicide, and we're looking at the hazard window. That's the 1 week window of interest, and that is the week before that individual died by suicide. And so we are, for each of these windows time, we are asking the question, did they run out of medication, yes or no? In the control week window 1, did they run out of medication, yes or no? And so we're doing this for each of these windows to see if there's, to test our hypothesis, is that we believe that most people will run out of their medication in that hazard window, which is that week before they actually died by suicide. So we use the insurance claims database, again, the Arkansas All Payers Claims Database. And the reason why I say that this is an untapped treasure is because not only do you have access to medical claims, but you can link those medical claims to birth certificates, you can link it to death certificates, you can link it to pharmacy claims, dental claims. I mean, it is very, very impressive in terms of what is captured with this data set. And so we were able to take the medical claims to see if they saw a provider, to look at healthcare utilization during that window of time. We were able to look at pharmacy claims to know whether or not that medication was filled, and we were able to calculate when that person was expected to run out of their medication. So in the pharmacy claims, they have the fill date, they have the quantity, they have the day supply. And so we were able to run some calculations. And so if a person, had a 30-day supply of a prescription that was filled on April 1st, we would anticipate by May 1st, if they took it as prescribed, that they will run out of their medication. And we were also able to account for individuals who may have refilled their prescriptions early and account for that in our regression analysis. So our study population consisted of Arkansans who died by suicide from 2013 through 2021, regardless of age. They must have had continuous representation in the All Payers Claims Database in the 3 months before they died by suicide. So in essence, they would have to have medical coverage, insurance coverage, consistently during that 3 months before they died by suicide. We did exclude people if they did not have any medical claims or pharmacy claims, because again, we're interested in those people who are taking these psychotherapeutics in the 3 months before they died by suicide. And we were able to identify these medications using the National Drug Code or the NDC codes in an ontology that allowed us to classify these medications, because I'm not sure if you guys, I'm sure y'all know about NDC codes. For one particular medication, you can have hundreds of NDC codes based on the dosage amount, the day supplies, the method of ingestion. So we just use this ontology to make it a lot easier for us. So after we applied our inclusion and exclusion criteria, we ended up with approximately 853 people who met our criteria, our study population for this study. And so here are some very high-level descriptive statistics about the study population, but what I want you to really hone in on is at the very top, we had 145 individuals who exhausted their medication in that week before they died by suicide. And we had 708 people who did not exhaust their medication in that hazard window or the week before. Now, that 708 individuals, they may have run out of their medication at other points of the study period, but we're really interested in that 145 individuals. So when we map out I'm going to turn my body just a little bit here. When we map out the trends over time, this is our hazard window here, okay? And then these are the different control windows. So did they run out of medication, yes or no? 17% of our study population ran out of medication in the 1 week before they died by suicide. And if you look at that compared to the other weeks, it's much higher. Compared to these other weeks, we're talking about a 5 percentage point difference between the week before they died by suicide and the week after that hazard window. Okay, and you can see that it's pretty stable throughout the duration of the study. So when we ran our regression analysis, this equated to about a 46% increase in the odds of running out of their medication in the week before they died by suicide compared to the other control windows. Okay? So we were able to establish that there is a temporal relationship associated with running out of medications and dying by suicide. Another thing that really stuck out to us was healthcare utilization, because that was kind of one of our sub-questions, is that was there a difference in healthcare utilization during that time period? Were people more likely to go to a provider? Were they more likely to be admitted in a hospital in that week before they died by suicide compared to the other weeks? And so here we can see that for non-mental health related claims, there was a 38% increase in the odds of them seeking a provider where a non-mental health related claim was filed. Why is this important? Because we know that a lot of mental health disorders may manifest themselves as GI issues or as headaches. There may be somatic symptoms associated with it. So this is letting us know that they're reaching out to seek care in the week before they died by suicide. When we look at mental health hospitalizations, even though that's not significant, with a p-value of 0.1, it is trending towards an increased association. But look at non-mental health related hospitalizations. More than a 3-fold increase in the odds of seeking care or being admitted in the hospital in the week before they died by suicide, where a non-mental health related claim was filed. And so this is just looking at it graphed out over time. So this is looking at mental health related claims. Outpatient is here, this dotted line. This is inpatient, where they're admitted in the hospital, less likely to be seen in a outpatient in the week before they died by suicide. But look, kind of out how it trends out, almost 20% in that first control window where a mental health related claim was filed. And then this is looking at non-mental health related claims being filed. So we have the hospital admissions almost double in the week that they died by suicide compared to the first control window. So again, these individuals are seeking care. They are reaching out to providers in some way, shape, form, during that time of distress that they in the week before they died by suicide. So through this project, again, we were able to establish that there is a temporal relationship between running out of medications and dying by suicide. And it's important to know that providers should closely follow patients who are taking their medications, receiving treatment, and explore options that will make it easier for patients to receive their medications. And then patients should also consult with their providers if they are considering wanting to stop taking their medications or wanting to taper their medications. So as with any project, there's going to be limitations associated with it, right? So the first thing is that we do not know that our study populations took the medications as prescribed, right? They could have been getting it filled, setting it off in a corner, right? And we don't know. We can only go by the claims that are being filed. So that is a limitation to this study. Another limitation is that psychotherapeutic medications, as you all know, is a very broad category of medications. And there are implications associated with that. Another thing that we do not know is other time variant factors. So we don't know if there was a loss in the family, if there was a financial issue that may have instigated the suicidal thoughts or was a trigger for somebody dying by suicide. And believe it or not, there are studies showing where weather can impact suicidal ideation, right? And then last thing is that it's difficult to look at the residual effect of the treatments, right? So some medications will stay in your system much longer than others, and that's going to vary. Certainly want to give a shout out to the research team who helped with this project. Again, this all started as a class project, and I was taking a course under Dr. Martin, and I had an idea already in mind and what I wanted to do, and he challenged that idea, and he was like, well, why don't you look at people running out of medication? I was like, I don't think there's going to be anything there, and so he and I, we talked, we went back and forth on it. He was able to convince me to pursue this, and so this is the result of it. Where it was published in Journal of Affective Disorders. And these are my references, and thank you all so very much for this opportunity. I don't know if we have time for Q&A or, no. Yes, ma'am.
Enough to, sorry. What I ask is, when I'm reading the statistics and that kind of thing, they often say they suppressed the data because they didn't have the number that they needed to actually count it. How much of that is a problem?
No, that's a great question, and something that we deal quite a bit when we report out statistics. And so the Department of Health, we have a policy where if there's a value less than 10, when we stratify it by different populations, demographics. So we wanted to look at how many black males die by suicide due to overdoses. You're talking about a very small population, and so because of that, we can't report those numbers out of risk of identifying people. And so a lot of times, even at the national level, they'll suppress. I think theirs is 20 at the national level. So if you go to CDC Wonder, they will suppress values that are less than 20, but in Arkansas Department of Health, it's less than 10. Suppress our numbers.
Okay. So one of the big things we see for psychology nationally is prescription privileges. There are quite a few states who have enacted legislation to allow psychologists to prescribe a narrow band of medications, which are usually psychotherapeutics or ADHD medication. And it has been brought up through our state legislation and kind of suppressed, and it keeps going back and forth a little bit. Where do you see the impact of prescription privileges for psychologists in Arkansas impacting what you found?
Yeah, so I will say that the more providers that we have who are trained in, administering and prescribing these medications, I mean, it's going to be a win. I don't see any downsides to that. Now, I'm not a practicing clinician or anything like that, but just by this project alone, I mean, if we have more people who have access to providers who can prescribe medication, who are trained in that area, I think that will be that could do nothing but benefit the state and Arkansans in general.
Is there any data or any research happening regarding lethal suicide attempts by gunshot or by like a medication leading to either a penetrating or anoxic brain injury and surviving it, and then reattempting again post-discharge from the hospital?
Yeah, yeah, there's quite a bit of literature that's out there where we know people who have previously attempted suicide are at a greater risk of further attempts, right? And now when we look at that by mechanism, whether it's a penetrating injury versus non-penetrating injury, I'm not necessarily sure on the literature on that, but we do know that there is an increased risk for repeat attempts. You know, yeah.
Thank you again, Dr. Porter. I was looking at some of your stats. Was there a particular, I don't know, antecedent or anything you saw why the Southwest rates were so high for committed suicide?
Go back here.
Sorry to make you go
Oh,
back.
no, it's no problem at all. So, yeah, the southwestern part of the state. You know, I don't know. And it's difficult to say because, again, we're kind of looking at very narrow slithers of the population, right? And you may have a increase of 4 or 5 suicides because that's, not necessarily a very populated area. So you can see a massive jump in their suicide rates because the population is relatively small. So I would need, we have an injury epidemiologist who's been tracking a lot of that information, looking to see if there's trends associated with the with different regions, within different age groups, and it kind of goes all over the place. And so I just wanted to present the latest year of data that we had available. But no, excellent question. Oh, yes, sir.
I came in a little bit late, but my question's in regards to the suicide rates and access to open therapy and things of that nature. Is there any research trying to figure out if that also could have affected the data? So yes, 2 weeks before they start taking their medication, they may have passed away, but did they have access to their psychiatrist or anybody in that field?
Yeah, so I think we were able to see that with them being admitted into the hospital for non-mental health related conditions. We saw it trending in the direction of outpatient outpatient visits for mental health related conditions. And so they are reaching out seeking help from someone. One thing that we do know is that there's a shortage of psychiatrists and mental health providers. And it's very difficult to get in when there's a crisis situation. My wife, she practices here as an LCSW, and it's difficult. I mean, her schedule is consistently packed, right? And so to get in with the provider when you're having a crisis moment is extremely difficult.
I've got a question. I don't know if you can answer that, but how
I will try.
how do you see the connection between like a TV show that is maybe even created to create awareness about suicide, to deter people from go that way, and then still it leads to an increase? I remember I'm from Germany, and there was in the 80s there was a show that was called Death of a Student. And it was on public television, everybody was watching it, and it was really there to create awareness, to help with prevention, and suicide rates spiked in that year among youth. So how do you, what is the connection there? Shouldn't it be a deterrent?
It should be, one would think, right? And so one thing that I didn't go into detail, so there was a study that was published where they analyzed Google searches for suicide 19 days after the release of 13 Reasons Why, and they found that searches for suicide increased by 19%, or 900,000 to 1.5 million more searches than what was expected. There was another study where they used national data to conduct a time series analysis where they used homicides as controls, and they found that the series, 13 Reasons Why, was associated with an additional 200 additional suicide deaths among 10 through 17-year-olds. So I think it's really speaking to how the media has to be responsible, right? And so again, I didn't watch the series, but from what I was told, it kind of glamorized it in a sense. And so I think when that message of glamorization is put out there and where people are already seeking attention in some way, and so they see that as a method of getting attention and they use that as a means. And so, and you're talking about very impressionable adolescents where their brains hadn't necessarily developed fully. And so they see a show like this and they're starving for that attention, and they will, typically see that as a means of getting attention. So, yeah. Yes, sir.
Hi, thank you for your presentation. I am super curious about the suicide rates, particularly of young people, because your presentation was a lot about the treatment, and that's super important. But I also am curious about prevention methods,
Yeah.
especially for young people, since it's happening so soon. Mm-hmm. So what are some ways do you think that we can go about preventing this suicide issue instead of the treatment side?
Yeah, no, absolutely. That's a great question. And I will say that, school-based interventions, there's been a lot of studies on that. They help a lot. But again, I think it really boils down to resources that we have available, especially in the rural parts of the state where you don't necessarily have access to programs or providers who can, do those school-based therapies. I also think a lot of it has to do with parents being educated when, as to when their child may be showing warning signs or symptoms of depression, things of that nature, and really being in tune with what it is that they may be dealing with. I know me growing up, we didn't talk about mental health. That was something that you didn't talk about. You sucked it up and you moved on, and that was it. That was kind of my upbringing. But I think now we're seeing a paradigm shift to where I know even with my son, I say, I check in with him often. Hey man, how are you doing? Like, how are you mentally? Like, and so I think that we have to be more in tune with it. There are interventions out there that, a lot of them are school-based or after-school-based. But, I think we have to get parents okay with the idea of their child seeking treatment or needing mental health treatment or therapy or, whatever it is, so that they can be more in tune and help, be on the preventative side, the treatment side of things, instead of a reactionary type situation that we have to deal with.
And on the same lines as the prevention and youth and kind of seeing where 13 Reasons Why was that increase, I work with kids and adolescents, and the thing that I'm most concerned about is the fact that they have unlimited access to short form videos all the time.
Social media.
Oh my gosh. And what is, I'm sitting here and the data goes to 2023 and we're seeing more and more usage in our adolescents with short form videos. I mean, have you heard anything about where the trends are going with that, or what short form videos and TikTok are doing to suicidal ideation or attempts or mental health in general?
I will say, I mean, the research around it is still so new. There's, a lot of people are really focusing on screen time, right? And its impact on the developing brain, mental health conditions, things of that nature. I will say social media plays a huge role in the mental health of our young, impressionable, individuals. And again, I often reflect back on my youth growing up. Whenever there was an issue, let's say somebody got into a fight, right, or had a disagreement, it was really isolated to those individuals. But now with these videos and things going viral, the whole world is able to see your moment of embarrassment. And so you're getting ridiculed by people you've never met, you don't know. And so just think about the toll that would take on someone who is so young. One of the things, looking at the data, we have people as young as 10 years old dying by suicide. And it's just absolutely mind-boggling to think that a 10-year-old, would do something. But it happens a lot. And so, again, I think that we have to really be in tune with our youth and really pay attention to the things that they're going through, and the impact of social media and having, their phones on them 24/7.
Thank you all for your questions. We have time for 2 more questions. So you have a question, and then Dr. Griffin, and then after Dr. Griffin, I'm just going to ask her to turn it back over to probably Dr. Judd at that point.
Thank you so much on your presentation. I'm still kind of stuck on the whole 13 reasons why causing a spike in suicide rates, just because I find it fascinating that a show can make such a big impact on our youth. And I just have kind of 2 thoughts in mind. So the show isn't just 1 season. They have, I think, a 2nd season and a 3rd season. So I was wondering if you also looked at, with subsequent seasons, were there also an increase in like suicide ideation or something of that nature? And I was also, another thought that I had in mind was there was another show, I believe it came out in 2021, 2022, called Euphoria, that was also very, very popular in our youth. But looking at the data, I didn't really see an increase in suicide rates during that time period. So I was wondering what the difference is between Euphoria, which discusses the same topics as 13 Reasons Why, which is depression, drug use. So I was wondering the difference between Euphoria and 13 Reasons Why.
Full disclosure, I haven't seen either, but I did read about, especially 13 Reasons Why. I mean, and really that was a fascinating deal, because I think what we may have seen was that they received so much backlash during that first season, and that the writers may have pivoted in terms of how they dealt with or addressed suicide in their series, going forward. I just think that the first one was such a big jolt to the system, and that may have, I would like to give them credit, or give them more credit to think that wasn't intentional. They wasn't meaning to do that. And so they responded to that backlash and may have adjusted following seasons. And so that's probably why we didn't see that big of a spike in the subsequent season releases. And I imagine the same thing for Euphoria. They probably looked at what happened with 13 Reasons Why and took a page from their lesson and said, we're not going to make the same mistake, and may have treaded a little bit easier or a little bit more lightly, carefully. That's my hypothesis. Again, not having seen either.
First of all, Dr. Porter, thank you for this presentation, the work that you're doing, and being with us to share this very relevant information. My question is this: in our current socio-political economic climate, what is the Department of Health and what are Arkansans who study this area anticipating lies ahead with suicide in Arkansas? Or are you addressing that yet?
Fantastic question. One thing that I can say is that, we know that a lot of people are at risk for losing their health benefits, right? And the Department of Health has remained committed to still provide services in our local health units. We have approximately 90 throughout the state where we can provide basic clinical care for patients, regardless of insurance status, regardless of residency status, citizen, non-citizenship. They don't ask any of those questions. They are there to provide those services to those individuals. There's some limited, even maternal health services that they provide. And so I'm so happy that they, even knowing this, that they're not going to get reimbursed for these services that they provide, that they still are committed to, providing those services. In the space of mental health, again, maintaining the 988 suicide hotline and making sure that we have our resources up to date and linking people with those resources. They're tracking those statistics, and I will be sure to, so we're in the process of creating a dashboard for 988 services where we just show some very high-level statistics, the type of calls that are coming in, how long they are staying on the phone. Our operators are staying on the phone with individuals who are in crisis. And there's a dashboard that's going to highlight suicide statistics as well, that even will highlight some information among the veteran population. And so, I will say that the Department of Health, they remain committed in the space of addressing suicide or mental health issues here in the state, and by providing those data and resources, and I think goes a long way. Thank you all so much.